And we got into the so-called clinical rotations, like surgery, which was rough because you had to work really hard during the day and sometimes late, and then you had to take call a lot, and that could be stressful. Plus, I maintained my job. So after a few of burning the candle at three ends, I just went crazy. I mean, I had sort of like a nervous breakdown. I got like really, really paranoid. I couldn't sleep anymore. It was like really, really, really horrible. And so, luckily enough, we had a very nice dean, and she knew what was going on, and she adjusted things to where I could, kind of chill out for a while. But I want to tell you something you may already know, especially now because you're going to be going into the clinical years, and that means a lot of work responsibilities. It means you still may try to carry on your regular work responsibilities as well, even though you're taking call and perhaps working long days in clinics. The body doesn't know when enough is enough. You're not going to get a warning. Your body isn't going to say, oh, well, you're stressing me out a little bit too much. No, you're going to either flip out, you're going to have a major accident, you're going to do something, and it's going to be totally unpredictable. So my advice to you, as long as I'm trying to give you advice, this is something I forgot to mention when I talked about the enemies of your medical career. But the thing you have to remember is to don't try to burn the candle at three ends. Maybe two you could handle for a while, but three, and in a few weeks you're gonna really, really, really be in bad shape. And your body isn't gonna warn you carefully and slowly and calmly. So I thought I would try to warn you. And I know that's a good tip. And if you've been to people that have been through medical school, especially the tough clinical years, they're not tough because you have to read a lot. They're tough because they consume a lot of your hours. So a lot of you already have jobs. So if you try to do a surgical rotation call plus your regular job, be very careful. Don't burn the candle at three ends. Okay, I'm assuming you're all still hearing me pretty well, and I'm assuming that you're all in class, and I'll do a quick look to see if you're in class. And yeah, I see a lot of green things there, so I guess you're in class. So let's talk about diseases of head and neck, or ENT. As the pattern, I want to say something about this chapter. I always tell you, oh, this is my favorite chapter. Well, this is my favorite chapter. I like it because it's short, it's graphic, it's logical. You don't have to take a lot of notes. And really, that's pretty much the way ENT docs think. They're not very profound. They love graphics. They love to look in your ears and down your throat and do surgery. In general, really, really, really good people. I haven't met too many bummer ENT docs. No, they fight with each other, but we all do, don't we? So our objective is going to be classically what the model has been for the entire systemic pathology rotation. And that's to basically look at the anatomy and histology of the area that we're talking about, and then think of it in terms of its normal anatomy, its normal physiology, its normal histology. And we're going to generally and logically think about things of those areas that could degenerate, become inflamed, or proliferate into benign or malignant neoplasms. And ideally, that is what the model we're taking for all these chapters, except some things like, developmental diseases, don't always quite fit into this beautiful category. So once again, we'll be talking about a lot of diseases. There'll be a lot of graphics. And once again, back to basics, like chapter 1, always think of every disease as having a cause or etiology or risk factors, something that evolves on a cellular level, perhaps even before the expression of clinical symptoms, and then the deviation from normal anatomy, whether it's gross anatomy, microscopic anatomy, radiologic anatomy. And then, of course, it wouldn't be a disease unless the patient had some kind of symptoms, some kind of sign or symptom. So here we go. That was a nice model we had before, but we're going to look at this again. But first, I want to look at this one. If you want to really, really remember a good tip for the anatomy of the head and neck and the so-called different regions of the pharynx and that, just open your mouth, look into the mirror, and see your little punching bag, you know, the uvula, the most posterior and inferior portion of the soft palate, and put a little pointer right there, and of course then go all the way down to the next little tip called the epiglottis, because that is the key area to understanding the anatomy of this area. If you drew a theoretical line between the tip of the uvula and superiorly the tip of the epiglottis, everything anterior to that is oral cavity. Everything posterior to that is oropharynx. Everything inferior to that is laryngopharynx, which for all practical purposes can be thought of as being the larynx too, but technically the laryngopharynx would also include this area a little more posteriorly. Everything superior to that is the nasopharynx. Now remember, the nasal cavity is not the same as the nasopharynx. The nasal cavity is everything between the nasal septum and including the actual nose cavity as well. But we talk about nasal cavity, the anatomy of the nasal cavity. We're talking about that big open area on each side of the nasal septum, which of course is inside the skull. It's not that little piece of cartilage you feel outside of the skull on your nose. And those are the domains. Now here's the general principle. You know all of these cavities have to be lined by some type of epithelium or mucosa. The general principle is, if these spaces generally touch only air, in other words, not each other, like food or another vocal cord, if it touches only air, theoretically, most likely it's going to be lined by a single layer of columnar epithelium. And as you know, upper airway, like when we get to the trachea, like we were in the trachea, we said that it's generally a pseudostratified ciliated columnar epithelium. So think of your sinuses that open up into the cavities. Think of the spaces themselves, but they're only interfaced with air. It's probably going to be columnar. If, however, it has to touch food, or in the case of the larynx, if it has to touch each other, like the true vocal cord, or what we call the vocal fold, then it's going to need a few more layers of cells, so it's going to be squamous. And it's all non-keratinized squamous. Of course, in the oral cavity, which has to touch a lot of food, when you are grinding food up against that hard palate, chances are the hard palate is going to be a little bit keratinized. So that's basically your anatomy and histology. And we might as well start, you know, in the first place we talked about, the oral cavity. So we talk about disease of teeth, gingiva, alveolar bone, inflammatory, reactive, leukoplakia. What does that mean? That's a term that's almost used exclusively for the oral cavity, and that's tumors and cysts and so forth. We go into the upper airways where we talk about the nose, you know, the nasal cavity, which is different from the nose, the nasopharynx, or the part of the pharynx that's superior to the uvula but posterior to the nasal septum, the so-called paranasal sinuses, and you know there's three pairs. There's the ethmoid sinuses, there's the maxillary sinuses, there's the frontal sinuses. And then we're talking to the larynx and the different things that could go wrong there, basically inflammations and tumors. Remember, once you get into the trachea, you are now technically into the lower airway because the trachea bifurcates into the lungs, and the lungs is lower airway. So to tell you the truth, I don't even remember if the trachea itself is considered upper or lower, but it doesn't matter because you know what it's all about. Here's another principle to remember if you want to save a lot of time and think logically. If you have a mucosa that is lined by a certain type of epithelium and has a certain general common function, even if it's not the same thing, for example, the nasopharynx and one of the nasal sinuses, then that epithelium is going to be subjected to the same pathogens. It's going to have the same potential for epithelial proliferation, in other words, tumors. So a good general thing is to say if something has the same kind of mucosa, it's going to be subjected to the same types of things that cause inflammations and tumors. We're going to talk about the ears. The only degenerative thing I could think of that's common is otosclerosis. But we talked about the regular inflammations and neoplasms, and those are your three categories of disease for the ears. We'll talk about the neck, common conditions like a bronchial cleft cyst, thyroglossal duct cyst. You have to remember a tiny bit of embryology for that. And then we'll talk about the only weird tumor that's kind of specific to the neck, the paraganglioma, or tumor of the carotid body. And you remember the carotid body, just like the carotid sinus near the bifurcation of the internal and external carotid artery. There could be a little tumor that's interesting. And last but not least, we'll talk about salivary glands. Glands, you know, we already talked about the histology of them. We'll talk about the chief degenerative disease where it's not making the juice, or xerostomia. You know, xero means dry. Stoma means mouth, dry mouth, because your salivary glands aren't making saliva. Inflammations and neoplasms. The two main type of benign neoplasms and the two main type of malignant neoplasms. And as you would guess, they would all generally be in the category of adenomas or adenocarcinomas, because salivary gland is a gland. Good place to start is the tooth. Regular old tooth decay. If you watch commercials for toothpaste, you probably already know more about this than I do. You know the anatomy of the tooth. You know that the enamel, basically, once it's made in the adult tooth, you don't get more. So if there's something that's eroding that, which you call caries or a decay, that's basically the main problem of kids and young adults. You know the dentin, you know the pulp chamber, you know the roots. You know how it's embedded in alveolar bone. You know it's the periodontal ligament that holds it into the bone. So what are cavities? What are caries? What is generally tooth decay? Well, it's a disease of civilized countries, especially countries where food is processed a lot, especially carbohydrates. You eat a lot of sugar, you get a lot of cavities, as simple as that. The main bacteria that is involved with this is strep mutans, type of streptococcus. The lactobacilli are often indicted, but that by itself is not a specific horrible pathogen. You know, your mouth has about 200 different strains of normal bacterial flora, and these things are, I guarantee, in all of them. So it's basically other factors involved. For example, the lack of brushing, which introduces alkali to neutralize the acid, the presence of fluoride, which strengthens the teeth by virtue of interacting, you know, with the enamel to strengthen it. The spacing between teeth, the closer your teeth are spaced, the less likely it is for saliva to generally keep it washed and therefore bacteria to build up. You know, tartar and plaque, you know, the stuff that you spit out when you go to it's basically all part of the same spectrum. Tartar is basically that gooey stuff that you get, you don't brush your teeth for a day, turns harder when it gets into plaque, which is what they basically sort of chip off when you have to have your teeth cleaned every now and then. Calculus, finally, is even something that's harder than plaque. The substances themselves are conglomerates of these different bacteria. These two are notorious, but other ones, different types of inspissated protein, as well as dead cells. So here's the question, folks. Where's the cavity? Looks like pretty nice normal enamel here. I guess if you were looking at this carefully, you would see that there's an area of this white enamel down here that looks like it's eroded. So that's your cavity. And as you guess, you know, that would probably show up if you took a good set of x-rays as a area of enamel loss of integrity as well. So much for tooth decay. I don't think we should spend more time on it. Let's look at the greatest single disease of adult teeth, or periodontal disease. And the reason why it's called periodontal disease is because it's not really the tooth itself. It's the surrounding soft tissue and bone structures. So a periodontist would be somebody that treats periodontal disease. The earliest expression of periodontal disease, you know, if you sit in your dentist's office and sit in the chair and you see these horrible pictures of teeth and they show how they progress, and they do that to make you guilty so you come back and get your teeth cleaned more often. But it's basically, it starts out as a gingivitis, okay? And the gingivitis is largely bacterial. And if you want to know the 2 or 3 species that are the most prevalent in gingivitis, which is the earliest form of periodontal disease, it's the actinobacilli. See, I have a little typo there. The porphyromonads and the Prevotella. Even though you maybe have not heard of those or can't pronounce them too well like I did, those are basically the 3 big species. There's generally more than 300 types, however, in your mouth. There are more bacteria in your mouth than in Milo's mouth or Sandy's mouth. So it's better to be licked by a dog and kissed by one of your schoolmates. What's the overall pathologic process? We're talking about etiology, pathogenesis. It's bacteria. Those are the 3 things. And it's a progression again. Remember, it starts out strictly as a gingivitis. If that progresses with age, with lack of proper care, whatever, even diabetes is a big factor. Most diabetics have a lot of periodontal disease. You have a lot of everything. Eventually, if it involves inflammation and weakening of the periodontal ligaments, well, you know what happens there. The tooth falls out. It also involves the alveolar bone, the alveolar sockets of the maxilla and mandible, and well as the cementum also, which is the counterpart of bone in the tooth as well. So that's an overview of periodontal disease. No reason to spend much more time on it. And here we go. This is going to be a very, very, very graphic chapter. I love this chapter because it's what pathologists should be showing, pictures of diseases. Here's a fibroma. You don't know it's a fibroma. All you know is that it's a bump on the cheek or a bump in the gums. And of course, because it's lined by the same mucosa the oral cavity is lined by, non-keratinized squamous mucosa, you'd have to take a section of that like you see down here. And if it basically looks like it's all fibrous tissue, or in other words, fibroblasts, collagen, maybe a few blood vessels, because everything needs blood vessels, you'd call it a fibroma. Technically, you would think, because of our original classification, that fibroma has to mean tumor of fibroblasts. Well, it does, but a lot of people don't even consider these true neoplasms, because a neoplasm is a clonal proliferation. This is just kind of an overgrowth of fibrous tissue, and that's why it's given the term irritation fibroma, implying it's derived from a process which is chronically irritating the mucosa. That's why they're very, very common in people that have dentures. Why? Because the denture is irritating the mucosa. The mucosa is reacting by fibrosis, and therefore you have an irritation fibroma. So the answer is, could dentures cause a tumor? Yeah, I guess if you consider a proliferation of fibrous tissue a tumor or a fibroma, they certainly can. Here's another nodule of the oral cavity, usually gingival. And you might think it looks like a fibroma, except it's a little pinker than a fibroma. And in addition to that, if you pressed on it, it would turn white for a few seconds. That's what they call blanching. And after a few seconds, it would be back down to its regular pink color. Now, if you pressed on a fibroma, it probably wouldn't blanch very much. But if you press on a pyogenic granuloma, it will blanch. Why? Because it is loaded with blood vessels. And the pressure on that blanches it, because it gets all the blood out of these big, wide open spaces, and then it comes back a few seconds later. Now, I know what you're thinking. You're thinking, well, Dr. Minarsik, Could these pyogenic granulomas with time, if become more fibrotic, turn into fibromas? Of course, the answer is yes. That's a logical conclusion. However, I can also tell you, like the fibroma, which is probably not a true neoplasm, if you did a histologic section of this, like in the quadrant I'm looking at in the Florida quadrant here, if you look at the irregularity and prominence and richness of those blood vessels and the fact that the intervening stroma has a lot of inflammatory cells, if you were to show that quadrant to any good experienced pathologist in the world, and you were to say to him, could this be regular old granulation tissue or organizing inflammation? He'll probably say yes. And then you say, ha, I fooled you. It's a pyogenic granuloma. And he'd say, well, you know, pyogenic granulomas are basically granulation tissue anyway. The problem is they have the name granulomas. So the one thing pyogenic granulomas aren't are the classical granulomas. You know, it's just a term we have to live with. Here's a canker sore. They're also called aphthous ulcers. You've all had them. They may be called cold sores. Fact is, after all these years, you could probably read a million articles with people giving theories as to what causes it. The fact is, nobody still really knows what causes it. And that's why you can always use the term obscure etiology. You know, some people say they're related to deficiencies of B12 or other vitamins, or, you know, they come with colds. That's what they call, or stress or fatigue, hormonal changes. The fact is, nobody really knows what causes them. You know what they are. You know they're painful. If somebody implied there might be a viral etiology, that's still obscure. Let's just say your regular old canker sore is an aphthous ulcer, frequently goes away, could be very painful, and don't ever try to figure out what causes it, or if somebody tells you they know, they're full of baloney. Well, if inflammation of the mouth is called stomatitis, if inflammation of the skin is called dermatitis, anything that inflames the tongue is called glossitis. Glossitis is not a specific diagnosis. It's the sum total of anything that theoretically could make the tongue red, inflamed, or have the all cardinal signs of inflammation. Hot coffee could do it, okay? Could a virus do it? Yeah. Could bacteria do it? Yeah, just like in the skin. Whatever causes dermatitis in the skin could theoretically cause glossitis in the mouth. Could it be due to hot spices, things like tobacco? Oh, yes, yes, yes. Could it be allergic? Yes. Sometimes you'll hear the term geographic tongue, if you've ever heard that. What that means is that if only part of the tongue is going to be inflamed, or maybe the earliest to become inflamed, it could very well be somewhere in the midline, and it won't be perfectly symmetrical. It might look like this. So when they talk about a geographic tongue, they mean a glossitis, and they also mean a tongue that may look like a certain country. Like, I personally think this looks like South Carolina, but, you know, somebody said it looks more like India. Somebody thought it looked a little bit like Ohio. So that's why they call it geographic tongue. Okay, well, now you know what the big one is, don't you? Herpes. That's a vesicle. That's herpes simplex. A wide variety of herpes viruses, herpes simplex, infecting mouth and oral cavity, corner of the mouth. You know, the word herpes does not mean vesicle. The word herpes means snake, because these vesicles, by their behavior, they kind of crawl and spread like a snake does. I don't know if that's a good description or not, but that's what herpes means. You know, a herpetologist is a snake expert. So theoretically, you know, there's all kinds of herpes viruses. Classically, they said the oral herpes was more type 1 and the genital was more type 2. But, you know, there's so much overlap. You don't really want to be too pedantic about that anymore. This is the early stage of herpes when it's a pure vesicle. Okay, don't think that's the only way you'll ever see it. These things can rupture. They can get a little secondarily inflamed, even with bacteria. They can be a little more sore, so there's a herpes. Here's herpes that's starting to show a little bit of granulation and pus. These are all the spectrum of herpetic. And if you notice, they all happen to be sort of like on the lip or near the lip in the oral cavity or on the skin next to the lip. That's generally a great place for herpes. There's a lab test called the Zank smear. I guess you'd call it a silent T. It's named after Dr. Zank. I never met him personally because he died 7 years after I was born. Arnold Zank, and he had a very, very good test, and has been done in the lab, and it's related to the fact that if you look at these vesicles, whether they're fresh or medium or secondarily inflamed, if you look at the squamous mucosa, they have viral changes, which means they're bigger and darker than usual, and they may have prominent intranuclear inclusions as well. Those inclusions are not the actual viruses. There will be viruses in them, but remember, the inclusions are much, much too big to be viruses. And you may see part of an inclusion here. You may see part of inclusion here. So the bottom line is, if a patient comes into your office with a vesicular, oral, or general lesion, you probably would think it's herpes, and you'll probably be right. But if you want to confirm the diagnosis, you could do a simple scraping of the lesion, and the squamous cells, some of them will look big and have inclusions and dark. You might even think they look like cancer if you're not experienced, but the fact is, these are the Zank cells. And if you get a positive Zank test, you can confirm the diagnosis of herpes without doing a whole bunch of other things. And of course, if you have a negative one, it still doesn't rule it out. And of course, these are a bunch of neutrophils with it because you know that the lesions will eventually break and induce secondary inflammation, perhaps even by bacteria as well. Okay, let's talk about another absolutely classical infector of the oral cavity. In fact, this substance is notorious for infecting any non-keratinized, moist, stratified squamous mucosa, including the groin region, including the esophagus. This is Candida, also called Moniliia, also called thrush mouth. There's a variety of other names for it. And it's often seen in babies. And what it's really often seen is, bottom line, is in anybody that may be immunosuppressed as well. And as you may know or not know, I mentioned it before, a person that is HIV positive, if he winds up having a Candida exudate like this on the esophagus, it's one of the criteria, at least classically, for changing that situation from HIV positive into, downright AIDS. Candida adheres to the mucosa. You could almost scrape it off. When you look at this, you could almost feel like you could scrape it off. And it looks like this. It's white. If you, for example, had a little PAS stain in your office, periodic acid shift, or even if you didn't, you see a bunch of the squamous cells here and here and here. Maybe you could see a neutrophil here, maybe here too. But look at the PAS stain goes to these fungal hyphae, and they stain it nice and red so you could differentiate it from the other junk that's on the slide. And as you remember, I told you that Candida in human tissue is usually dimorphic, which means not only do you see these little hyphae, or what they call pseudo-hyphae if you're a microbiologist, but you can often see little yeast forms, like that little round thing is probably a yeast, that's probably a yeast. And these little yeast forms create buds, and then the buds grow into hyphae, or they just multiply. Okay, let's take another common oral cavity condition called leukoplakia. And before you start getting crazy on me thinking this means something exotic, if you just go to the derivation of the word, leukoplakia, leuko meaning white, like a white blood cell, and plakia meaning plaque, because it looks like a little thick plaque on the squamous mucosa of the oral cavity. That's all that it means. All leukoplakia means is white plaque. If it's white because it's inflamed, Okay. If it's white because it's hyperkeratinized due to some irritating substance, that's okay. If it's white because of a bacteria or virus localized infection, okay. If it's white because there's some local process there, like the guy, chewing tobacco, causing a premalignant or dysplastic condition, that's all leukoplakia. Remember, all it means is white plaque. You see how nicely defined that patch is? Sometimes the leukoplakia has kind of a hairy, irregular delineation, or what you might call hairy leukoplakia. Yeah, you see a thickened white plaque, but now it's a little bit hairy on the side. I'll show you some more. Here's some more hairy stuff. Here's some more hairy stuff. Here's on the edge. Well, the reason why I'm showing you this is because you see that when your patients, they have AIDS, okay? Hairy leukoplakia is a strong sign for HIV infection. Now let's get into some more principles, because sometimes leukoplakia, whether it's inflammatory, irritation, whatever, the usual suspects, sometimes it's pre-cancer as well. But don't ever make the mistake of equating leukoplakia by itself to dysplasia. Here, let's take this example of the gross and microscopic. Here's a normal stratified squamous mucosa of the tongue, of the mouth, whatever. You see how it matures from the basal layer to the superficial layer. Notice there's no keratinization. Notice there's no hair follicles. That's why you know this is mucosa of the oral cavity rather than skin. Also because it's not keratinized. Let's say there's some substance or a chronic condition where there's a thickening of the stratum corneum, or what they call hyperkeratosis. Well, that's hyperplasia, isn't it? It's hyperplasia, especially in the superficial layers. If there is a process going on like carcinogenesis, this hyperkeratosis will, with time, months, weeks, years, mostly months and years, have a situation in where not only is the squamous mucosa thickened and hyperkeratotic, but you'll start to see, even at this power, that a lot of the cells look a little bit darker and more irregular, or what we call pleomorphism and hyperchromasia. If this progresses to become more severe, and there's more pleomorphism, there's more hyperchromasia. It gets to the point where these cells look like downright cancer, but it hasn't invaded the basement membrane. You can call this either severe dysplasia or carcinoma in situ. I don't care what you call it. If, on the other hand, you look at it and you could see that some of this is infiltrating into the underlying connective tissue, you call that an infiltrating squamous cell carcinoma. This is generally the progression of changes. Here's a guy that's 10. At 12, he starts to chew tobacco because his friends are doing it while they're playing baseball. A few years later, it still looks about the same, but if you look at it, there's some dysplasia going on now, perhaps progressing more time. Eventually, those will lead to infiltrating squamous cell carcinomas. So remember this, because this is the progression. This is very important. I should have made this slide yellow. Okay. What about this? Well, you can tell it's a mouth. You can tell those teeth look pretty gross. You can tell that there's some plaque on the tongue. Oh, look, there's an ulceration in there. And you know what? I know you're only looking at it, but if you could feel it, you'd probably feel that it was also indurated. So you're thinking, could this be an infiltrating squamous cell carcinoma? Yeah, it could be. In fact, it is. And in contrast to regular old leukoplakia or dysplasia, which shows a local thickening, an infiltration one, because it's infiltrating, will be evoking an inflammatory and fibrous response, so it'll really feel firm. And here's a nice picture. I think I don't have to go into great details. I think by now, hopefully, with all the lab stuff you saw, you can still recognize that these are squamous cells. You can see that a lot of them are bigger and darker than they should be. You can see this thing we call a pearl, which is a whorled collection of squamous cells. You can see some connective tissue here. This is a classical, well-differentiated squamous cell. And I know what you're thinking. You're thinking, well, what the hell's the difference between well, medium, and poor? Well, here's the difference. Any squamous cell. This could be lung, this could be oral cavity. We might as well get it out here. We talked about it before, and we'll talk about it again with lung. If a squamous cell carcinoma forms these little whorled pearl-like structures called pearls, you could call that a well-differentiated carcinoma. If you're seeing something like that, but you don't really see pearls, but if you look closely at some of the cells where you see the intercellular spaces, and I want you to look very hard here, you can see there's tiny little hairs going between those spaces. And if you remember from your histology, those are the desmosomes or the tonofibrils which connect squamous cells to squamous cells. That's how you know this is squamous, because some of them are still differentiated enough to have tonofibrils, but they're not as well differentiated where you see pearls. Nevertheless, in a poorly differentiated squamous cell, which you see down here at the bottom, you don't see intracellular bridges, you don't see pearls, but you do see things that still basically look like squamous cells, but they are much bigger, darker, irregular, pleomorphic, hyperchromatic. This is a poorly differentiated squamous on the bottom. This is a moderate here on the right, and here's a well on the left. By the way, if you're looking in your lab sections and you see a cell in which you could tell this is a mitosis, but rather than going like in a nice direction, you know, like away from each other, they look like they're going in 3 different directions. That's what you call an abnormal mitosis or a multipolar mitosis, because it's going in more than 2 poles during a mitotic division. You see a cell that has a multipolar mitosis. For all practical purposes, those are all cancer cells. Let's talk about cysts and tumors of the oral cavity now. There's a whole wide variety of cysts. If you look at Robbins or any of the oral path books, they have a whole bunch of names and a lot of them overlap. But if you want to really summarize them nicely without, you know, being a little oral pathologist, just remember there's 2 general categories. There's the ones that are ultimately resulting of inflammation of the tissues around the tooth, and there's the one that are developmental. You could call them probably embryologic remnants. And there's several in each category. For example, without a doubt, by far, the most common inflammatory cyst is called a radicular, not ridiculous, but radicular periapical cyst. And it results usually from pulp inflammation in which the surrounding epithelium becomes cystic, has a lot of inflammatory cells. The most common developmental cyst, or in other words, cyst that has been there probably since they were born, is a dentigerous cyst. And really, when you get a cyst from an oral surgeon, it's probably going to be a dentigerous cyst. It could be a radicular cyst. And then there's a whole bunch of other ones that you have to get out the book and look up. Of course, that same odontogenic epithelium, which gives rise to the developmental cyst, like the dentigerous cyst, can also form a malignant tumor as well, called an amyloblastoma. These are very, very rare. You'll never see one in your life. And to tell you the truth, I don't think I've ever saw one. Here's a dentigerous cyst. They're usually associated with impacted molar teeth. You see, here's a molar tooth. It's impacted within the mandible, and you can see a cystic space around it. You show that to a radiologist, or even better, show it to a dentist or an oral surgeon. They're going to know instantly that's a dentigerous cyst. It has a nice sort of squamous looking lining, but remember, even though this is a stratified epithelium and it might look like a low squamous, basically that's odontogenic epithelium, and that ultimately had or could give rise to a tooth. Okay, we're done with oral cavity. It's 9:47. We're half done. Let's do a little bit more, and then we'll take a break. Let's talk about the most common disease in the world. You know, the rhinitis, sinusitis, runny nose, sinusitis, so upper respiratory infection spectrum. You know, if you have a inflammation of the nasal mucosa or your sinuses, very, very often that's associated with allergy. And if you have an exudate or a drippy nose and you take a swab in your office and you look at it and many eosinophils are present, it confirms your diagnosis that this was of allergic origin rather than some other infection. They're usually associated with URIs. They're usually viral, but really, technically, I really would like to give this topic more time, but think about it. Anything that causes an upper respiratory infection involving the types of epithelium that we are talking about of the head and upper airways, just about everything in the world has been implicated at one time or another. You know, there are common viruses for the common cold. There's a whole list for this. So let's just, rather than saying these are the most common, let's just assume it could be anything. We're going to also mention that in the so-called nose, sinus, nasopharynx, remember, these are all things that are lined by, you know, simple columnar epithelium. You can give rise to tumors. And the tumors can either be things that are just kind of polypoid swellings of the mucosa called polyps, or they could be a true neoplasm involving blood vessels and fibrous tissue like angiofibromas. They could be benign squamous tumors that branch, which are called papillomas. They could be collections of plasma cells, which we call plasmacytoma. And I know what you're thinking. You're thinking, Dr. Menarshek, didn't you tell us that tumors of plasma cells can turn into multiple myeloma? Yeah, the answer is yes. Sometimes they could be isolated, and some people might tell you they'll never turn into multiple myelomas, but really, you got to be careful, because if you see a plasmacytoma anywhere, they're very common in this nose, sinus, nasopharynx area. This will, with time, eventually, you know, have a high risk of involving all the bones and secreting monoclonal proteins. Another tumor that's common to this area is a neuroblastoma, especially of the olfactory bulb. You remember the olfactory nerve is not really a nerve. The olfactory nerve is really those few little fibers that pierce the cribriform plates. And then once you get into the optic bulb, that's your ganglion. Then everything after that, they commonly call the optic nerve, but it's really not a nerve. It's a tract, isn't it? Because you are already past the ganglion. And of course, they have nasopharyngeal carcinomas. And as you might guess, they're going to look like they could be squamous or lymphoid, because there's a lot of squamous and lymphoid tissue in there. Here, this is a common run-of-the-mill nasal polyp. Nobody would really want to call this a true neoplasm, because all they are edematous, boggy bulgings of the mucosa, such that they sometimes look like little grapes. And here's your normal mucosa. Could this be pseudostratified ciliated columnar? Well, it should be, but it could also be squamous, because there could be metaplasia going on here. And here's a lot of inflammatory cells and edema underneath. And you could call them a polyp because they take up space. You shouldn't call them a true neoplasm, but the ultimate etiology is inflammation. Because of the edema in the mucosa, it makes it bulge and become boggy. And here's what it might look like on a MRI scan. You see, here's your turbinates, and here's like a little bulging thing, and here's another one. And remember, these are in the nasal cavity. They usually don't go into the nose themselves. You may see them if you put, you know, a little light through the nose, your nasoscope or otoscope, but they're originating in the nasal cavity, not the nose itself, you know, in the mucosa that is adjacent to and around, you know, your turbinates. And sometimes they can fill up an entire sinus, can't they? And they can look something like this. And if you're lucky enough to be looking in the guy's nose, and you could look deep enough from the nose cavity itself into the actual nasal cavity proper, you would see this edematous, gelatinous, bulging stuff. Very, very, very common. If you took a swab of this, and there were a lot of eosinophils, would you tell your patient they're probably caused by allergies? Yeah, you probably would. but you would still probably, sometimes they're very often surgically removed if they're doing a lot of chronic airway obstruction. You should also be aware of the fact that there is a couple of conditions we talked about before in the lung called Wegener's granulomatosis, which is kind of an autoimmune vasculitis. Very closely related to that is another often very, very serious infiltrating condition called lethal midline granulomas. And these are both very, very serious. Otherwise, you know, they wouldn't have the name lethal in them. And it is a both true granulomatous lesion. It's not like the pyogenic granulomas in which there weren't any giant cells and epithelial cells. These are true granulomatous lesions. They can be very destructive. And with immunosuppression, they don't have that high of a mortality anymore, but they're very serious. They can be very, very destructive. Aha, this is a great thing. Remember, we talked about papillomas before, and we defined a papilloma as any finger-like projection of connective tissue that is lined by an epithelium. And in this case, it happens to be squamous. We call this a squamous papilloma. Well, when you are in the nasal cavity, sinus, you know, upper respiratory mucosa area, you can get a papilloma. And of course, if it was malignant, you wouldn't call it papilloma, wouldn't you? You'd probably call it papillary squamous cell carcinoma. These papillomas can grow like trees, you know, and branch out like you see here, or they could grow like roots into the connective tissue underneath. So an inverted papilloma is a tree that decides to grow into the ground rather than above the ground. The reason why I want to point this out, because these inverted papillomas, sometimes they're also called inverting papillomas as a gerund rather than as an adjective, because the inverted papillomas have a significantly higher degree of relationship to carcinoma simply because they are growing more inward. But remember, each by itself, technically, by its name, would be considered to be a benign process. Otherwise, you'd call them squamous cell carcinomas, wouldn't you? Here's another tumor of that same nasal sinus area called angiofibroma. It doesn't take a rocket scientist to figure out. There's a lot of fibrous tissue here. And if you look closely, these are, or if you did a stain for endothelium, like a factor VIII stain, you will see that these are blood vessels as well. There's blood vessels here, 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 here. And all the rest of the stuff is basically fibrous-looking tissue. That's why it's called the angiofibroma. Totally benign. Doesn't turn into cancer. So you know where the angio part is on this slide, and you know where the fibroma part is. Here's a plasmacytoma. And you know, because I told you, that plasma cells have to have a round nucleus off to the side, peripherally distributed chromatin, like a clock face or a cartwheel, and a clear Golgi zone, or what they call HOFF, H-O-F-F, loaded, the Golgi being loaded with immunoglobulins. These are little antibody factories. And that's what a plasma cell looked like. And even the most malignant of plasmacytomas, which we call multiple myelomas, they still look like regular plasma cells. That's kind of interesting because a multiple myeloma can be as malignant as hell and still looks like benign plasma cells. They don't have to. Some of them look like horrible plasma cells where you can't even recognize them anymore. But the point I want to make, this is another area in the nasal cavity, another common tumor. I don't want to say common. If you find an isolated plasmacytoma, there's a good chance it came from the nasal cavity. And remember, we said before that isolated plasmacytomas with time have a high incidence of developing into downright multiple myelomas, where all of the bones and bone marrow is involved with plasma cell infiltrates, and there's an expression of monoclonal protein, usually seen as a gamma spike on the serum protein electrophoresis, or a protein in the urine, which we called Bence-Jones protein, or, the light chains from antibody molecules. Two more common tumors. I don't want to say common because, quite frankly, I don't think I've seen more than about 3 of these in my life. Neuroblastomas, and they come not from the nerve, but from the ganglion. That's why, if you remember, the olfactory bulb is actually a ganglion, and that's where most of these neuroblastomas of the olfactory area come from. They're also called esthesio neuroblastomas because I think esthesio is implying a sense, like a smell. And even if you kind of remember that you can get neuroblastomas of the of the olfactory bulb, remember, you will never, ever, ever be showed on an exam or by anybody a picture of a neuroblastoma of anywhere, even if it's a brain tumor in kids or a tumor in the abdomen of kids, unless you saw a rosette. So remember, when you hear the term rosette, the tumor, you're probably talking about blastomas. Last but not least, nasopharyngeal carcinomas, before we take our break. This is a nasopharyngeal carcinoma, and I know what you're thinking. You're thinking, oh, it looks like any other crappy cellular thing he showed to us. The point I want to make is if you look at this and you carefully examine it, you'll see there's enough invasion and thing. But often, because, the nasal cavity is surrounded by a lot of mucosal associated lymphoid tissue, the nasopharyngeal carcinomas often look like lymphomas because there's a strong lymphoid component to it. So if we were to look at this area in the middle, you would say, well, they look like epithelial cells growing every which way. And of course, if I could blow this up for you, I could prove there's a lot of mitoses and pleomorphism and all that junk. But in addition, you would say, well, it looks like there's a lot of cells here that look lymphoid with less cytoplasm. So almost all the nasopharyngeal carcinomas, even if they're squamous, have a lot of lymphoid component to them. We're done with more than half of this, and we're going to spend the next hour talking about the larynx and the ear and the neck and the salivary glands. So that's what we'll expect in part 2. And anybody want to ask any question or say anything? The only question I want to ask is, could everybody hear me clearly? Otherwise, I'm going to feel really bad.
Yes.
Yes.
Okay, good. Well, Margaret, you know what you could do in 10 minutes then, right?
Okay. Call you then.
And by the way, I know we've heard this before, but I really like this song.
to find out all you want. So talk to you later. Bye.
We're here. You here?
Okay, it looks like the dim window. What happened? Petered out on us?
It went out, but
All
I'm
right.
starting it up.
All right,
I
good.
think it went out during the break, which is nice and convenient.
Yeah, so that was good. So it's like timed for an hour, so.
Yeah, usually I give it an extra hour at the beginning. I know we haven't had 2 hours, so maybe this was a stupid thing. Anyway, it's coming back up.
All right, good.
So I'll be with you in about 8 seconds. You heard the pop.
Yep. Looks like we have everybody online too, so that's good.
Okay, great. It was a nice break. Uh, I thought that the Isla song was very nice, but I couldn't hear it that loud. I don't know if everybody else heard it loud. I bet mine was really loud. So let's finish the chapter on ENT pathology. I keep wondering if this extremely graphic approach is appreciated. For me, it's appreciated because it evokes images which are true disease and which I could talk about other aspects of the disease. And it doesn't, it means you don't have to take much notes or read much. But anyway, the ENT chapter, like ENT pathology, is very, very graphic and largely pictorial. Uh, these dogs, which you're all seeing, if you're not on the island, if you are on the island, you know who these dogs are. They are Amy and Annie. They are new additions to Destiny. Somebody dropped them off about a week ago. They're still not quite at the weenie stage yet. They're only about 6 weeks. I suspect when we get there in April, they will be bigger. And if you think they could be related to Woofy, I guess that's possible, but he does not claim paternity for these guys, you know? There were some DNA tests and the lawyers are after him, but Woofy says it's not his fault. So I believe him. So I imagine by now you can all see the nice little new puppies on Destiny. Now what you're seeing is a beautiful set of vocal cords. We are now in the larynx. As you know, the vocal cords are also called the vocal folds. They were formerly and even now commonly called the true vocal cords. There's another little fold just superior to them, which they used to call the false vocal cord. Now they call them the vestibular folds. And this is your phonation. That's where your vocalis muscle is, a lot of supporting muscles. It's still considered upper airway. And it's interesting because technically it only touches air, right? Unless something goes down your windpipe. But the part of it that has to touch each other is probably sort of squamous. The rest of it is probably single cell columnar. And that's how you speak. When you don't speak too well, you get laryngitis. Probably the differential diagnosis of which would be, any uh, organism that infects the upper airway. You know, strep, of course, is big, 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 but it's also big in the throat, larynx, upper airways in general. And like you would expect, it's no longer nice and pink, it's red. It's hyperemic, it's red, it might be painful, all the cardinal signs of inflammation. When you think of the mucosa of the larynx, not only the true chords, but the false chords and the subglottic region and even the epiglottic, with that being the dividing line, you can get proliferations chiefly of the mucosa, so they're carcinomas, okay? You can get a benign bulging called a polyp, just like we talked about bulgings of the nasal mucosa being inflammatory polyps. You can get bulgings of the laryngeal mucosa, especially near the vocal cords, which are called Singer nodes. And they're not named after Dr. Singer. They're named after the fact that singers get them a lot because they're belching out their vocal cords all the time. You can get benign proliferations. They frequently grow like trees, or you call them papillomas, or sometimes these papillomas can infiltrate and be a downright carcinoma. It's easy to tell the difference grossly microscopically between a polyp and the other two, but sometimes the differentiation between papilloma and carcinoma could be tough. But you don't have to worry about that. You look down somebody's throat, you look at the vocal cords, you see a very smooth surfaced little bulging nodule. You know that it still has a nice shiny mucosa. You know that's a Singer's nodule, okay? That's a benign vocal cord polyp. I actually went to Wiki when I was reviewing this last night, and they had a list of all of the common rock and roll singers that have had these at one time or another, and I was amazed. There's probably about 60 or 70 people there, and if you have to probably stereotype or profile them, just think of people like, Rod Stewart or, Bob Plant from Led Zeppelin, the ones that sing kind of raspy, like maybe Janis Joplin or Vito Corleone, because these things cause your raspy voices. Of course, if they're removed, you could talk and sing normally again. Sometimes they alter your voice, and that's really the first symptom of them. Here's a papilloma. You can see that here's a mucosa. It's relatively smooth, but you can see some increased vessels going to a proliferation of the surface tissue. And if you look at that, it would be covered by squamous epithelium usually, and having a fibrous tissue core. I don't know if you could appreciate that from the gross, because I'm not going to show you a picture of it. But the thing is, there's no ENT doc in the world that could call it a papilloma. They always send it to us to see whether there's malignant changes, which could be very subtle. Okay, so here is a tumor now. You can see the false vocal cord just superior to the true vocal cord. And you can see growing in the supraglottic region, a tumor which is irregular, probably indurating it. And this is what a carcinoma would look like. They're pretty much all squamous because that's what the mucosa here is a lot. And if they did a laryngectomy, you would see these bulging things coming out of either the false or the, excuse me, or the true cord or something in between. The reason why we put India ink, the shiny India ink on these specimens, is because if we look at the surface of the India ink and the tumor does not extend to the ink, in other words, you don't see ink on the tumor, you could tell the surgeon, yeah, you probably got it all. And that's not 100% good technique, but it's logical. If you coat a specimen with India ink and the tumor cells microscopically do not touch it, then they don't touch the surface. In other words, they got it all. But, it still could have metastasized. Here's a squamous lining on the surface of one of these carcinomas. You'd be hard-pressed possibly to call this cancer, but look, what do you see underneath? Look at all these big cells with glassy cytoplasm, dark nuclei. So if the question was, is this carcinoma infiltrating or not? Of course it's infiltrating because you have all of these tumor cells underneath your basement membrane here. This is an invasive squamous cell carcinoma. If it had pearls, you'd call it well differentiated. If it only had little bridges between some of the cells, you'd call it moderately. And if it looks so nasty you could barely tell it even looks squamous anymore, then you call it poor. This is probably in the range of moderates, because I have a feeling if you blew up these little areas like this, little spaces between adjacent cells, you'll probably see some intracellular bridges. Okay, let's move up to the ear, from the throat to the ear. Otitis externa, all it is inflammation of the external ear. Probably the same diagnosis as dermatitis. You know, the ear is a little more subject to trauma than the rest of the skin. Things like cold, as well as the usual skin bacteria, anything you could think of, fungi, you know, infections. That's basically otitis externa. I don't think we have to be too fancy about this. The ones that we do have to be fancy about is the inflammations of the middle ear, or otitis media. And as you know, the outer ear goes all the way to the tympanic membrane, and here's a tympanic membrane, and then the area from the other side of the tympanic membrane to the eustachian or auditory tubes is the middle ear. And here is the world's most normal looking tympanic membrane. It's nice and smooth. It's glistening. You can see the arm of the malleus here. This little bump is called the umbo. You'll see this when you get to ENT lab or clinic. There's always an area here that where you see the reflection from the light of the otoscope. That's called the cone of light. It's always in this certain place, you know, just usually anterior. I believe that's anterior to the umbo. If you want to visualize what the underlying structures are, you're looking at the malleus. That's the umbo. You know that the chorda tympani, part of cranial 7, is in there. There's going to be other bones. You can see the incus is a little bit further down. You probably can't see the malleus because it's really too far away. And you're going to get the tendons of these little muscles like the stapedius and the tensor tympani, you know, controlling these little things very, very finely. Well, let's say you looked at this and it wasn't red, it wasn't swollen, it wasn't painful. And now you got one that is red, swollen, painful. And what's the fourth sign of inflammation? Well, whatever it is, probably heat, right? This is otitis media. And as you could guess, these are inflammatory changes in the middle ear, very, very common in kids. You know, in kids under 2, it's almost always Haemophilus. It could be strep. It could be anything that infects the upper airways. This is an acute otitis media. Here, you would say, well, this kind of looks like a normal tympanic membrane. But look, you see that little fluid level? That's water in there. That's what they call a chronic or a serous otitis media. The acute fibrinous, all the acute signs of inflammation have receded, and now you just have a kind of a nice water level exudate here. So the chronic otitis media is frequently called serous, and basically it's when you're basically looking at fluid on the other side of the tympanic membrane, but not much by way of other signs of inflammation. Here's something very common. The ENT guys tell me this is probably the most common reason why people get their come to the ENT doctor for the E parts of it or ears. This is a plug. This is cerumen. This is that big waxy stuff that builds up. It can interfere with hearing. My dad had these all the time. They're just as common in women as in men. It's basically an oversecretion of cerumen. And remember, cerumen often is secreted as a protective response if there's inflammation. So yes, they are associated with otitis externa. Now, I don't know, if any of you ever probably go for a ride with me, unless I often take the key and I scratch my ear if it itches a little bit. So, you know, maybe I'll wind up getting a lot of the same stuff that my dad did. This is what these plugs can look like. They're basically conformed to the cavity of the middle ear, and they can become secondarily involved with cells and blood. Probably the blacker part has some blood. But this is basically just a big plug of wax, you know, long chain fatty acids made by your cerumen glands in the ear. Now, let's go to the parts of the ear that we can say has classical degenerative disease. Otosclerosis, okay? It's a very subtle disease. I wouldn't be surprised if I have it because I don't hear as well as I did. My dad had it. It's the most common cause of a conduction hearing loss. And the reason why it's a conduction hearing loss is because it's kind of like a thickening or a fusion of this obviously stapes looking structure, or the stapes, the stirrup, with respect to the oval window. If you remember, the stapes ends at the oval window, and this is just a sclerosis of bone in that area. It's probably as common as degenerative arthritis itself. So if you think of somebody's hips overgrowing with bone and cartilage as part of osteoarthritis, you can think of the same process in the joints. And remember, these are synovial joints. These little tiny little bones have synovial joints with respect to the stapes as well. Okay, we got the three parts of the ear, the common conditions. Let's move down to the neck and talk about a couple of things. Bronchial cleft cysts. You remember in embryology, you got your bronchial clefts. They develop into a whole bunch of things like parathyroid glands. And I can't even remember. I should have reviewed them, but you should remember that. And the classical presentation is kind of a cystic soft swelling on the side of the neck, right in this region. Notice it's lower than the parotid gland. It doesn't really feel like a lymph node. And they are basically embryologic remnants. They can become inflamed. They don't become malignant. We have a doctor friend here at Rosalind Franklin that had one of these, and he was told it never becomes malignant, and then they biopsied it later on, and it was malignant. So then they changed their diagnosis from bronchial cleft cyst to carcinoma of the base of the tongue. But generally, these cystic things can become swollen, inflamed, and as you might guess, they're probably lined by some nice epithelium, like probably a squamous. And now let's talk about more embryology. You remember how the base of the tongue connects to the tip of the thyroid gland in embryology? And sometimes that little connection can remain. And sometimes it could remain as a little cyst. And sometimes that cyst could become inflamed also secondarily, because technically it's an open structure. And really, if you have a cystic structure exactly in the midline of the neck, and it's not really the thyroid, it's not really the tongue, that's a thyroglossal cyst. And the way you could prove it is if it's removed, which it often is for cosmetic or other reasons, and you can see little tiny thyroid follicles inside of it, then you know it's a thyroglossal duct cyst. If there are no thyroid follicles, it still probably is anyway, because I really can't think of anything cystic structure exactly in the middle of the neck at that location. Let's get into one other weird neck tumor, which occurs really nowhere else in the body. I don't want to have to review all your branches of the external and internal carotid artery, but if you remember, where they do bifurcate, there's something called a carotid sinus and a carotid body. And if you remember, the carotid sinus you could actually see because it's a little bit of a bulging right at the bifurcation. And the carotid sinus you can't see. You have to believe it's there, but you can't see it. And as you know, the carotid sinus is involved with CO2 acid regulation and so forth. And the cells that are involved in that can become tumors. And these are called carotid body tumors, appropriately. I want to tell you, they're also called paragangliomas commonly. And I think that would not be fair if I didn't tell you that if you looked at these tumors, they look like little balls of cells. And the German word for little balls of cells is Zellballen. So sometimes a pathologist that want to look smart, they'll say, I see the Zellballen. So anyway, despite all of the confusion and nomenclature, just remember, you see somebody with a carotid body tumor, also called paraganglioma. They're benign. It's going to occur in the area where the carotid body is. But remember, if these are big enough because of their location, right in the carotid artery, they could do some, significant problems with blood flow in that area. They should be removed. Most of them are. Last but not least, we're going to talk about salivary glands. You have 3 pairs. You have approximately just as much salivary tissue associated with your oral cavity as you have salivary gland, but this is accessory salivary tissue. all throughout your upper airway, oral cavity, all of these little mucus and serous glands. But where they form significant specific glands, the submandibular gland, also called submaxillary, which confuses things. But the best name is submandibular because they are the main occupants of the anatomical submandibular triangle, the parotid gland and the sublingual gland. And if you remember, we said if you have a salivary gland that has both these mucus, which you see here and here and here, this white stuff, as well as serous, which is what you see here, if it looks like it's a good mixture of both types, it's probably going to be a submandibular gland. If you see one that is in 100% serous, it's probably going to be parotid. If you see one that's going to be 100% mucus or almost 100% mucus, it's going to be sublingual. This is a normal histology of a submaxillary gland. Inflammation, with the classical signs of infiltrates of acute and chronic inflammatory cells, is sialadenitis. Basically, acute one would be a lot of neutrophils, chronic one would be a lot of lymphocytes. That's the basic rule. If there was a stone blocking a salivary gland duct, do you think that that would be a situation where you could have secondary inflammation? Yeah. You know that viruses infect salivary glands, especially mumps. You know that other bacteria can. And as you might guess, some of these ducts of the salivary gland, if they are subjected to inflammatory changes, remember, we told you that if a salivary gland duct is frequently like a cuboidal or columnar, if it's associated with inflammatory or irritative changes, it could then become metaplastic to be squamous. So this is a normal reactive process, could occur anywhere where there's glandular tissue. This is squamous metaplasia of a salivary gland duct. And I don't know what salivary gland duct it is, but I see a lot of mucinous acini here, so it's probably not parotid. Here's a mucocele, almost always occurring in the lip. And this is a cystic inflammatory lesion of an accessory salivary gland. Remember, the lip has is loaded, oral cavity loaded with accessory salivary glands. Well, this is an example of an inflammatory condition of an accessory salivary gland that winds up expanding, perhaps plugging the gland and becoming a cyst. And as you might guess, you can see a lot of inflammatory cells here. And you can see that the cystic space then fills up with junk, including mucus. That's why it's called a mucocele. And you can have mucoceles other places, but generally, when you hear mucocele, you know it's probably going to be on the lip. Here's a classical place for a swelling of a parotid gland right at the angle of the mandible. Could this be inflammation? Yeah. Could it be tumor? Yeah. All you know is that it's swelling. And usually it doesn't have to get very big before you see it kind of impinge upon that lobe of the ear. You know, I have a brother-in-law that doesn't believe in doctors. You know, I don't blame him. I really don't believe in him either. But he wound up having a big tumor in that region. Now it's been there for 30 years. It's about the size of an orange. And you could almost see the disappearance of his earlobe. But I'm sure it's a benign salivary gland tumor of the parotid, because if it was malignant, he would have been dead 20 years ago. And he really lucked out. He just doesn't want to see a doctor. Here's a kid with mumps, chiefly involving the left side. They could be bilateral. Usually they're one more than the other. And if I try to convince you that these were inflammatory cells infiltrating salivary gland tissue, you'd probably believe me because you seem to believe everything I say. But in actuality, this is a seminiferous tubule. You can see primary and secondary spermatocytes. You can see some sustentacular cells like right here. This so just reminds you that mumps not only has a tremendous affinity for salivary and pancreas and exocrine type things, but also in males, you know, the testes as well. Here's a classical appearance of a submaxillary, or I should really say submandibular gland, shouldn't I? because if you went back to your anatomy books, and I hope you do, and know what the boundaries of the submandibular triangle are, you know that the submandibular gland is really the main occupant. So when you take anatomy and you look at that gland, you know you're in the smack dab in the middle of submandibular triangle, one of the many neck triangles. Let's talk about, as a last topic, salivary gland tumors. And we know they could be benign or malignant. And there's a whole bunch of them. And as you might guess, because the salivary gland is a gland, the benign ones would generally be called adenomas, and the malignant ones would be generally called adenocarcinomas. That makes sense. Classically, the single most common tumor of salivary glands is a benign tumor. And in the older days, it was called a mixed tumor, and a lot of people still call it a mixed tumor. And the reason it's called mixed is because it is an overgrowth both of cartilaginous as well as epithelial-like structures. That's why it's called pleomorphic. Pleo means many, so it's an overgrowth of both connective tissue, which looks almost like cartilage, but it's really myxoid connective tissue, and glands as well. The second most common one, something that in the old days is called a Warthin's tumor, and then somebody decided to name it papillary cystadenoma lymphomatosum, but really nobody really took on to that. They still call it Warthin's tumor. But if you remember it as papillary cystadenoma lymphomatosum, you know the histology and appearance. These are both classically benign tumors. These are by far the vast majority, 90-something% of all benign salivary tumors. The malignant salivary tumors are all adenocarcinomas. Why? Because salivary gland is a gland. A lot of them express mucus as well as squamous-like characteristics. So the most common one is a mucoepidermoid, and I'll show you that. It'll stain for mucus. Last but not least, a lot of them is adenocarcinoma, and the little glands almost look like little cystic spaces, like little thyroid tissue. So that's why it's called adenoid cystic. Here is your classical pleomorphic adenoma. It's well encapsulated. It's what my brother-in-law has. You can see it's an overgrowth of something that looks like cartilage. Doesn't look like cartilaginous matrix or mucoid substance. You can see there's also some glandular proliferation around it, which look nice and well-formed. That's your pleomorphic adenoma or mixed tumor. Here's the Warthin's. And if you really knew both names, that would be nice because everybody calls them Warthin's. But histologically, here's your papilla, here are your cysts, and here's your lymphoid tissue. So it's a proliferation of salivary gland tissue in which you can see little cystic spaces between the papillary-like structures, but the cores of the papilla are also very, very rich in lymphocytes. That's why, if you remember, that Warthin is also papillary cystadenoma lymphomatosum, second most common benign salivary gland, you'll be very fortunate. Here's a mucoepidermoid, and I really hope I'm at the stage where when I say something like this, you don't think I'm just gobbling Latin terms, because think about it, epidermoid means squamous, right? And if you look at these tumor cells here, they look like it's kind of like a squamous cell carcinoma, doesn't it? But in addition to that, in the middle of these squamous areas, you can see like junk. And if you stain that junk with a mucin stain, or what we call mucicarmine stain, which is the main stain used to identify true mucin in the lab, you'll understand why it's called mucoepidermoid, because it's basically an epidermoid or squamous-looking thing, but you can see abundant little pools of mucin in it as well. And remember, when we looked at the other squamous cell carcinomas, like in the larynx or we get to the lung, you're not going to see usually an abundance of mucin, you know, within squamous or epidermal cancer. Last but not least, adenoid cystic. There's something to be said about this tumor. It's not that common compared to mucoep, but it's still the second most common malignant one. And as I told you, it looks like the little glands are forming little cysts. They're not just little tubules, but they look like little, you know, thyroid cysts. But the thing to remember about adenoid cystic, it's a cancer, it's malignant, so you know it could kill you, But the fact is, classically, it's a very, very, very slow-growing tumor. And very often, you'll see a person with a bona fide diagnosis. They won't do anything to them, and they'll still have it 20 years later. The interesting thing about these little cystic-looking glands is that they have some crazy predisposition to invade along the nerves. So if you're lucky enough when you take out a salivary gland and you see a nerve, you're very, very likely to see these little cystic spaces growing. So take home for adenoid cystic is that it looks adenoid and cystic, grows slowly, and frequently grows along nerve, has an excellent prognosis for a carcinoma. We're done, and it's early. And, I know a lot of times I keep you until like the last minute, and you're probably thinking, shit, isn't he ever going to let us out early? Well, I'm going to let you out early today. And I could have looked at a whole bunch of lab cases, but we'll save those for next week while the knowledge of ENT is still fresh in our memory. So on Thursday, we'll take 5 or 6 maybe salivary gland and oral cavity or larynx lesions from the lab. We'll look at them quickly, and then we'll start with probably the biggest chapter of all called GI. There's almost 200 PowerPoints on that, so don't freak out. Today there were only 79, so we were able to whip through that in like 2 hours. It's going to take a whole week to do GI, maybe longer. I don't care because we're in no rush. Anybody want to ask questions or tell jokes? Anybody want to compliment Isla for her beautiful music selection? Does anybody want to ask Iman if the Rolling Stones are as invigorating as Tai Chi? I don't know. There's all kinds of things we could talk about before we leave. Q, are the Rolling Stones as therapeutic as Tai Chi, or is Tai Chi more invigorating? Well, she just said she loves it. Okay. She probably loves both of them. I'm glad you heard me. Oh, Tai Chi is tough, but Rolling Stones is easy on the ears. Okay. So let's say they both get your blood going, but with the Rolling Stones, you could just sit back. How's that? Okay, folks. Go home. Have fun. We'll see you on Thursday.
Okay.
Bye-bye.